Good evening, everybody. Welcome to tonight's webinar, COVID Care in the Community, South Eastern Sydney HealthPathways Update. So thank you for joining us tonight. I'd like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. We recognise their continuing connection to land, water and community and pay respect to elders past, present and emerging. We also extend that respect to any Aboriginal colleagues who may be joining us today. My name is Brendan Goodger. I'm the General Manager of Primary Care Improvement here at Central and Eastern Sydney PHN. With me I have Dr. Martina Gleeson, local GP, HealthPathways Editor, and has taken a very strong statewide role in the development of COVID care pathways. We also have Anna McGlynn, who's the HealthPathways Manager. So welcome, Anna. And we also have Dr. Kristen Overton, who is an infectious diseases physician at Prince of Wales Hospital. So thank you for joining us tonight. Please note that the webinar will be recorded and will be available on our very own YouTube channel within the next couple of days. Now look, what we would like tonight is to have some good questions. So pop through the questions on the chat. And what we'll do is we will ask them in the second part of tonight's hour-long seminar. So to start off with, can I welcome Martina to take us through COVID care in the community, South Eastern Sydney HealthPathways update. Tell us what's been happening. Thank you.
Thanks very much, Brendan. And thanks, Bertha, for also organising it. I'm Martina Gleeson. I work in the Sutherland Shire. I'm the GP Clinical Lead of South Eastern Sydney HealthPathways. I'm also the Senior Editor of the New South Wales COVID Collaboration HealthPathways. So why is this not advancing? Here we go. So the learning outcomes. By the end of this activity, you should be able to use HealthPathways to assist you in managing COVID-19 positive patients, identify patients who need escalation of care, and know how to escalate care using local resources. Here's just a snapshot of what the current situation is on data that was shared with us today. In the last 7 days, we've had 23,436 new PCR positive cases just in our local health district, 24 COVID-19 related deaths, 3,800 cases in South Eastern Sydney residents in the last 24 hours. So that's combined RAT and PCR tests. 296 COVID positive inpatients, 28 in ICU, and 86.8% of our residents over the age of 12 years of age have had 2 doses of the vaccine. Please bear in mind that some of the hospital data doesn't include St Vincent's numbers. In New South Wales, in the last 24 hours, 29,830 positive cases. 13,763 of those are positive RAT tests that have been logged in with the Service New South Wales app, and 16,067 on PCR. 2,850 patients in ICU with COVID-related disease, 209 in ICU, 63 ventilated and 36 deaths. Okay. Just to share this is a little bit, what's the word, unofficial. It's been shared, but it gives us an idea of how much the vaccine protection you get is, and you can see down here in this bottom, the hospital occupancy, the orange line is the unvaccinated and the blue line is the fully vaccinated. And then over here on the right, the ICU occupancy, again, the blue line just starting to take off amongst fully vaccinated, but the unvaccinated people are clearly carrying the burden. If you need any encouragement to keep trying to get your hesitant patients vaccinated. So we could see that things might have been heading in the direction of an increasing case burden towards the end of last year. And so as far back in September, we had some emergency meetings between HealthPathways and the New South Wales Ministry of Health, and assigned a small team of senior clinical editors from around New South Wales, including myself and Kate George from Sydney and Amy Newen from Sydney, to try and rewrite and simplify the health pathways that we had and make them really relevant to general practice. The agencies involved in the collaboration were the Ministry of Health, the Agency for Clinical Innovation, and the Sydney Children's Hospital Network, with actually a wide variety of clinical experts involved all over the state in COVID care as our clinical governance committee. So we're very grateful for all of the helpful input we've had. And as a result of that work that we started back in September, we developed these new pathways, self-care patient triage and support. That was actually only developed in the late December. Active case management, shared care of case management. That's for how to look after your patients with their non-COVID related conditions if they're already under the care of the local health district team. Case management tools and resources, COVID isolation support, and PPE infection and exposure management. We've also got some other helpful pathways on the South Eastern Sydney. COVID-19 requests is where you'll find a lot of the important information about how to escalate care and how to contact the local teams. Post-COVID-19 conditions for those patients that might be having extended, prolonged symptoms after their COVID infection. COVID-19 mental health support and the vaccination procedure pathways are very helpful and are kept updated very well by the lead region, which is Nepean Blue Mountains. I'm going to hold this up for you for a little while so that we're all familiar with using QR codes now. And so if you've never used HealthPathways before, I'm giving you an opportunity to use the QR to log in to the South Eastern Sydney or to the Sydney HealthPathways sites. I've also got the addresses up the top for you and the login details. So for South Eastern Sydney, the username is SE Sydney and the password is healthcare. And the Sydney password is also shared with you. But because we're both in the same PHN, you can use the Sydney login to access South Eastern Sydney, and you can use the South Eastern Sydney login to use the Sydney pathways. So if you happen to be working sort of on a borderline and you've got some patients who live in the Sydney local health district and some people that live in the South Eastern Sydney local health district, especially for COVID and especially for trying to find who do I escalate to, please use the pathways that your patient lives in that district. That should make life easier for you. The clinical content is the same. It's the individualised how do I get care part that is localised. So now I'm just going to stop sharing here so that I can start sharing a live demonstration for you. So just double checking that you can see that now, Bertha.
Yes, we can.
Great. So there's two appearances of HealthPathways. Oh, what have I done? Here we go. This is the classic, and then there's also the mobile friendly, which is designed to track down more of a vertical screen so that you can use it on your mobile phone. This is the home page, and you can see over here on the left-hand side, you've got the option to find all of the COVID-19 pathways. We've got them. And every time in HealthPathways, when you see a little white cross in a blue box, it means that there's a drop down. So the COVID-19 vaccination pathways are there, including the side effects, although we should all be quite familiar with those now, having been vaccinating for the last 10 months. The clinical care pathways are the ones that we're very interested in today. And that includes the PPE, infection control and exposure response, the self-care patient triage and support, the active case management. I'm going to spend a lot of time looking at these two today. And then some case management tools and resources for you. This one is assessment and management in residential aged care facilities and the post-COVID-19 conditions. You'll also find some helpful pathways on MBS items and telehealth, and the requests and supports are the other important ones. So how to get isolation support for your patients, how to access the teams when you need to contact them to escalate care, and some mental health support as well. I'm going to have a look first at the active case management pathway and this is for people that you are looking after in your general practice. So there actually isn't going to be a lot of them now that most patients have been put onto the self-care pathway, but you are going to get patients who say I'm low care, but I feel really bad at the moment and I need some advice. And this can be helpful for you to help identify how you can help your patients. This is a new feature in Health Pathways, COVID Pathways, is this what's changed, new and important changes. And if you've looked at the pathway last week and you're not sure if it's been updated, this is where you find out, because it tells you when the last update was. So on this pathway, it was the 12th of January, and what changed in that time. So if you're fairly familiar with the pathway, but you're not sure what's changed, this is a great place to start when you're looking at the pathway. And then, of course, always in Health Pathways, we start with red flags. And these are agreed red flags for across the whole of New South Wales. So I know that not everyone has an oxygen pulse oximeter, but if they have oxygen saturation less than 94% on room air or 3% lower than their baseline, is a red flag. And you can read those. I'm not going to read them for you. This is a bit of a description of active case management, what we're trying to do. And one of the things we've done with these pathways is we've combined adults and children into the one pathway. Because if you're looking after a family, if there's a child that's sick, the adult's probably got it as well. If there's an adult that's sick, the child's probably got it as well. So we want you to be able to find the information you need for everybody in the household that you're consulting at the time. And then it looks like it's very short, because what we've done is we've tried to make it very usable. So if you're only talking to a patient about isolation and, I've had COVID, I'm day 8, do I have to have my booster? Then you just go to that section of the pathway, and you'll find the advice for release from isolation. You'll find a link to the medical clearance if they need it. But patients who have registered using their rapid antigen test will get a notification and medical clearance from New South Wales Health, I think within 24 hours of registering their result, saying when they will be medically cleared to leave. So you shouldn't have to provide that form. They also get sent a copy of the New South Wales fact sheet, but you can also access that fact sheet there. And then there's information about the timing of vaccination after a COVID infection. And the current advice is if they've had monoclonal antibodies, then they need to delay vaccination until 90 days after they've had the monoclonal antibodies, because they have those antibodies in their system, and that stops them from developing an immune response. If the patient has not had a primary course, it is recommended that you start their COVID vaccination as soon as they've recovered from the acute illness. If they're due for the second dose of the vaccine, they should have it when they've recovered. And there's no requirement to delay their primary vaccination. But if they've had a primary course and they're due for their booster, it's reasonable to delay their booster for 4 to 6 weeks after their COVID infection. So there you are. I see lots of questions out there on the interwebs about that. So there's that information for you. We're going backwards, but this is also the information that you'll need if you're doing your first consult with the patient to assess them because they've requested your assistance. So, and it gives you an idea for, checking the first thing you really should do is is check the red flags, make sure that they don't have them, and if they do, escalate their care to the hospital. Although it says here, if they're not critically unwell, then escalate their care. Sorry, that advice is the GP advice line. That's going to be changed tomorrow, and it's going to say the CTAC team, and I'll show you where to find that information on the pathway. And then it has a summary of what are mild symptoms, what are moderate symptoms. It also has a suggestion for a monitoring checklist that you could copy and paste and email to the patient or get your staff to email to them. It's got a list of the high-risk medical factors if you're not familiar with them, the sorts of things that you should be concerned about. These people probably need more intense monitoring than other people without too many comorbidities. And there's your drop box to find what are the indications for monoclonal antibody. At the moment, we've just got sotrovimab listed on the pathway because the alternative monoclonal antibody, which is casirivimab and imdevimab, there's some questions over its efficacy in treatment of people with Omicron. So we had it in the pathway and then we took it out. But if you have a patient who is high risk, you'll be escalating their care to the local health district team and they can make the decision about what treatment they get anyway. But there you go, there's the indications. And there are also indications for children, so be aware of that. It also talks to you about the indications for budesonide and gives you advice about how to manage symptoms. I mean, it's all fairly basic GP stuff, but just in case you're feeling maybe intimidated because it's COVID, this can be reassuring that yes, we know how to do this. We know how to manage these typical viral symptoms. And then talking about high-risk protocol, which is for people with high-risk medical risk factors and moderate symptoms, and the low to medium risk protocol. And then, as always, with Health Pathways down the bottom, we have a request page that gives you advice about how to get help with managing the patient. Always down the bottom of Health Pathways, we also have some helpful information, like if you want to go and do more reading or you're trying to find some resources for health professionals and also for patients, and a copy of the sources that we've used to develop the information. I want to tell you a little bit about the self-care patient triage and support. This was developed when we were first heading towards more community management of low-risk patients. And then as the case numbers got up and the health system was getting overwhelmed around December and Christmas time, it really became apparent that more and more patients would be managing at home. And there were a lot of GP practices closed, a lot of health services closed, a lot of PCR collection centres closed. And so we really were looking at trying to change our mindset to more of this is like a disaster, and we need a disaster response. We need to set our triage goals and we need to work out what's the most important thing to do and then do what we can. So that we're looking after each other and our patients. So again, a summary of the important changes, including the ability for patients to register their positive rapid antigen test on the Service New South Wales website. And I have to say, I'm very impressed that New South Wales has not only said here, register your test, but also when you register, the patient who registers their result gets a questionnaire, which is a screening questionnaire to try and identify those people who are high risk. And if they are identified as a person who might be at more risk than somebody with no comorbidities who's young and double vaccinated or boosted, they then get a secondary questionnaire which goes into more detail, and that helps automate a notification perhaps to the local health district that this is actually a high-risk patient that might need your care. So there's that opportunity for triage that's being done automatically, and you don't have to do that, which is helpful. So we inserted this section called Planning Your Emergency Practice Response based on the RACGP Disaster Management in General Practice guideline. So these are the sorts of things that you and your GP team can be working on to help things flow more smoothly and support everybody in your team. determining your practice goals. And the first one is safety and well-being of your team. And then identifying and escalate those who need hospital management. And then identifying and escalating patients who need early treatment with monoclonal antibodies, supporting those with mental health or isolation support needs. And then for everybody else, try to maximize their confidence and their ability in their management for everybody else. I'm not going to take you through all of this, but I really would encourage you to read it because it's quite a different way of thinking about it. It's not a business as usual way of thinking about it. And it just might help empower a lot of the members of your team to step up and collaborate together in your response. And then we've got different sections. You're becoming familiar now with the idea of Dropbox. So hopefully when you're talking to a patient and they're asking specifically about something, like you might have a mum who says, I've got COVID, can I breastfeed my baby? Then you know that you only have to open this section of the pathway and not the whole pathway. So we tried to make it so that you can almost see everything that's on the pathway on the one screen and then just open up the part that you need. The PPE pathway, also it has the new and important changes there, and then the helpful things are the risk matrix, the session for the risk matrix, and also the guidance for New South Wales Health at the moment for managing healthcare worker exposures, which allows us to try and have a way of keeping staff in the practice for as long as possible if they've been exposed but they're not yet COVID positive, but at the same time keep everybody in the practice as safe as possible. How are we going for time? Okay, so the other important page is the COVID-19 requests page, and obviously urgent assessment is, giving you your emergency department contacts. The COVID-19 hospital-led service, which is the CTAC team. There's a hotline, and then there's the contact numbers for the Prince of Wales CTAC team, and then the St George CTAC team, and also the St Vincent's Hospital Virtual Care Clinic. So you can find that information there when you're looking for it. The other thing, there's a GP advice line. So there's also the Health Direct video call service, the National COVID-19 hotline, the New South Wales COVID-19 care at home support line. And they do have an option when you ring them after you've listened to their messaging that goes for about 2 minutes to select option 4, which is you're identifying yourself as a GP to get advice. And so, yeah, that's where you can find your advice. We've also got the information that was provided to us from the PHN for accessing pulse oximetry for you if you're managing the patient, not the LHD, and you think the patient needs access to a pulse oximeter. That's how you organise it. Right. Just stop sharing the live and keep going with my presentation. And so just a summary of some of the things that have changed. All patients are now self-managing and are given advice on how to self-escalate if they're symptomatic or high risk, and that goes through their interaction with the Service New South Wales website or app. A positive RAT is now accepted for diagnosis without the need for PCR. And as you are aware, patients can upload their positive test. There aren't really recommendations for routine pulse oximetry, but if the patient's getting more severe symptoms, and you can access pulse oximetry for them, it's appropriate to try and organise it. And the dedicated options for GP on that New South Wales helpline is relatively new. The other things that you might not be aware of because you might have been on leave is that the 30-20 rule has been delayed until the 30th of June. So that means that you won't be penalised for doing more than 30 phone calls on 20 days of the year up until June of this year, although video remains preferable for COVID assessment. The 12-month rule of recency of contact with the practice still applies for both video and phone. But if the patient's in isolation, either because they have to isolate because they're a close contact or because they have COVID or they're waiting for a COVID test, the 12-month rule doesn't apply and you can provide care to those patients. And yay, this weekend, the Level C phone item number has been reinstated. It's the same as what it was last year, and it will be available to us until at least June the 30th of this year. I just thought I'd do a summary of who should get a PCR rather than a RAT. And this is people who are pregnant over 20 weeks, Aboriginal or Torres Strait Islanders, if they're unvaccinated and over 16 years of age, or immunosuppressed, or workers in high-risk settings. The goals of care, I'm summarising what's in the pathway now. So I've already said, identify and escalate patients who need hospital management or early treatment with sotrovimab or budesonide. Identify and support those who need mental health or isolation support, and really try and encourage your patients in their own ability to self-manage, knowing that they've got you there as their safety net. That's a summary of the red flags that are also on the pathway, just to give you a chance to have a look at them and get your head around what you're asking your patients to assess for and what you're assessing for when you speak to them. And signs of concern: tachycardia greater than 120, respiratory rate greater than 24, pulse oximetry less than 94 if they've got one, fever greater than 39 lasting 5 days, or fever greater than 38 in children, especially in little children, less than 1 month to 3 months. For those who aren't familiar with sotrovimab, it's a monoclonal antibody infusion, which is effective in preventing hospitalisation if it's given within 5 days of onset. And it's indicated in inadequately immunised or immunocompromised people. And we've left that deliberately vague because at the moment that's defined, I think, as 2 vaccines, but at some stage it's going to be, your primary course and your booster. And anyone who's immunocompromised, no matter how many vaccines they've had. If they have these other comorbidities as well, diabetes, obesity, chronic kidney disease, congestive cardiac failure worse than NYHA class 2, COPD or moderate to severe asthma, age over 55 or 35 if they're Aboriginal Torres Strait Islander. And then there are also indications for children, and I showed you where they were on the active management pathway. So how do you organise it? You can call, Kristen, I did this a little while ago. So the St George CTAC team or the Prince of Wales CTAC team, and both of those phone numbers are available in the request pathway, or email the team, or you can also get the patient to, by answering their questionnaire on the Service New South Wales app, they should also be identified as someone that should be assessed for the suitability of sotrovimab. So one of the things I've done is spoken to some of my immunocompromised people or people with significant comorbidities and said to them, if you get COVID, make sure you answer those questions that come to you on the Service New South Wales app truthfully, so that you are identified as someone who's in need of the infusion. You might not be familiar with budesonide. Well, obviously you're familiar with the medication, but the indication for using it in treatment of people with COVID. And these are the indications where it's suggested that you institute it. I just want to clarify that if a patient with COPD or asthma is on a different inhaled steroid, you wouldn't change them over to budesonide. You would keep them on their same inhaled steroid that they're on and follow their usual COPD or asthma management plan, considering bringing their steroid dose up to something that's equivalent to the budesonide 800 micrograms twice a day. How to get advice? There's the New South Wales COVID Care at Home line, option 4. But we also have our South Eastern Sydney local health district GP advice line, which is available 8 a.m. to 8 p.m. 7 days a week. And it'll take you through probably to a clinical nurse consultant who knows how to manage COVID, has been doing it for a while and can give you good advice. And then if it needs to be escalated up to a doctor, they have the capacity to do that. And then for your high-risk patients with deteriorating symptoms or to escalate to access sotrovimab, those phone numbers for Prince of Wales and St George, and they are listed also on the request page. Just one final thing that I wanted to bring up, and that is that we're all quite stressed at the moment. It has felt quite overwhelming, especially over Christmas and New Year, with people who are sick and unable to access tests. And actually, we've had people presenting to the practice for a face-to-face consultation and lying about their COVID status, exposing us and the team to unnecessarily. And I wanted to point out this beautiful resource by the Agency for Clinical Innovation called Pandemic Kindness, talking about being aware that looking after your team is actually really important at this time. I'd really encourage you to have a look at that website and have a think about how it might assist you to work together as a team, remembering that your team is really important at the moment. We're all a bit tempted to work a little too hard and burn out, and maybe this is just a little reminder to look after each other so we don't get too crispy. So any questions? I'll stop sharing now so that we can have other people log in.
Look, thanks, Martina. That was a really fantastic overview of health pathways and COVID. Really thorough, really detailed. Now, look, what I might do is throw a few questions at you, if I may.
Sure.
Because some of the questions that we've been getting in some of the other forums that I've been in have been ones around paediatrics.
Mm-hmm.
I wonder if you could outline for me, when should a child get their second vaccination shot? We know that there's a length of time, but when should they? When should they get their vaccination, their second vaccination?
Even though we're in an outbreak, and that's the wording in the ATAGI advice is a little bit confusing, isn't it? Because it says 8 weeks, but 3 weeks in an outbreak, and like this is a pretty big outbreak. But the current advice is still to do it at 8 weeks, unless the child has significant comorbidities and would be considered to be at high risk. And if that's the case, they've probably got a treating clinician, and maybe it's worthwhile checking with them. The advantage of waiting the 8 weeks is the immunogenicity is better, and they also think that it might reduce the risk of significant side effects by having that bigger space between the 2 doses. So you've got to balance the risk of the individual child that may have really high comorbidities with the probably better result in the long run if you do wait the 8 weeks. So our practice is currently doing 8 weeks.
Thank you for clarifying that, because I know there has been some confusion on that point.
Certainly has been. There was a discussion on the RACGP webinar last night about it, and also one last week, and that's the up-to-date advice from them.
Right. Look, we've got another question, if I may, which is, at the moment, we're all heavily involved in vaccinations and that kind of thing. For those people with long COVID, who are showing symptoms beyond, do health pathways also indicate where people can go for treatment and care for long COVID?
When there is treatment and care available, they do.
So what's your suggestions? So given that we've now had COVID for a couple of years, so what's your suggestions for trying to manage and deal with someone with long COVID type symptoms?
We do have a post-COVID conditions request pathway. But I have to tell you that there isn't a specific post-COVID-19 clinic available in our local health district at the moment, although we are advocating and trying to discuss and encourage. But it's a matter, it's a matter of availability and funding and developing models of care. There's all sorts of stuff going on in the background. But for example, if the person, you can refer to the individual specialties. So the ones who have been in hospital and had significant respiratory illness and have come home and they're still breathless and they still have lung problems, they can be managed by the respiratory physicians, and they can also access pulmonary rehabilitation. And we've got the details of those services in our local health district on the health pathway. If someone had myocarditis during their inpatient admission, they can be managed by the cardiologists. So we have got the links to the individual specialties and where you might send people with a particular complication of their COVID-19 disease. But that idea of the overarching post-COVID-19 outpatients clinic, it's not there at the moment, although it's hopeful that that will be developed with increasing capacity in the system.
Thank you for that. Now, look, I might take one of these questions live that's come through the chat. With the criteria for butanazide,
yes.
It mentions diabetes, someone who's diabetes, but not on insulin. Does that mean the criteria for sotrovimab, got that one right, about diabetes on medication means that insulin is not only on medication? So I think where people are going with this is, what's the criteria in relation to diabetes?
Well, I'm going to have to look up my health pathway because I haven't memorized it. So
right.
It's interesting. Yeah, it's interesting. Diabetes, I see what you're saying, not treated with insulin. And we've taken that from the Clinical Evidence Task Force. And I am going to have to review that and make sure that that is relevant. But maybe we could ask Kristen, because she's here with us and she's one of our clinical experts.
Kristen, help us out.
I'm not sure why it says not on insulin there. I would give it to any diabetic that requires treatment for their diabetes, whether that be oral or insulin. Same with sotrovimab. When it says requiring medication, it's just treated diabetes, not, diet controlled diabetes.
So thank you for that question. I'm going to take that on notice and review that part of the information on the pathway and possibly make an edit.
Well, thank you for putting that question. Now, look, for Kristen, I wonder if you could give us a bit of an overview. I'm putting you on the spot tonight, but give you a bit of an overview on what CTAC actually offers.
So the CTACs, the one at St George covers the Sutherland Shire at the moment as well. And the Prince of Wales covers sort of that LHD, and St Vincent's have one, and so does RPA Virtual for those in the Sydney Local Health District. Mainly look after just the highest risk patients of deteriorating. And so that tends to be, defined as our over 80 population, especially with Omicron, those with organ transplants or immunosuppression, active cancers, and in particular those that are unvaccinated or partially vaccinated, either over the age of 55 or 35 if in our Aboriginal or Torres Strait Islander populations, or have a comorbidity that puts them at risk, and therefore they would require sotrovimab. And so we receive referrals for those high-risk patients, give them sotrovimab if it's within the first 5 days of illness and they meet the criteria, and then follow them through the course of their illness.
Thank you for that. That's a really helpful response. Now, look, I might also throw to you, Kristen, because we've got another question coming through, which is a good question, which is previously third trimester pregnancy was on the high risk for consideration of sotrovimab. Has this been removed?
In an unvaccinated woman, third trimester would be considered for sotrovimab. And so I think, people might be referring in that question to when sotrovimab was first available, was not recommended in pregnancy, and the original trials didn't include pregnant women. But there has been advice coming out that it can be considered for women in the second and third trimester, noting that it may cross the placenta to the mother and baby. So there needs to be consent with that pregnant woman, but it is actually recommended, especially in the unvaccinated mums, if they're willing to take the sotrovimab, and it's been given to many pregnant women in New South Wales now, to prevent them from getting severe disease. In terms of Omicron, we're not seeing as severe a disease, as my gut feeling and my experience so far in our pregnant women compared to Delta. And given the large numbers of cases in this district, the women's hospital and the maternity services are those that are following those COVID positive women. And so we recommend that all women who are pregnant over 14 weeks contact their maternity care providers, and they're been following them up for us just to sort of distribute the workload.
And can I also say that on the health pathway for the indications for sotrovimab, it does say adults and pregnant people in the second or third trimester. So we're still recommending that in the health pathway.
And just to add to that, there is a draft ACI guideline going around, which is quite vague, but in its wording. And so we're asking for a bit more clarity. So there's clear guidelines, but we are expecting that those that are in those at-risk groups, including pregnant women who are overdue for their booster, which they've not clearly defined yet, but I think it will sit at about either 4 months or 3 months, post-second dose will also be sotrovimab eligible.
And we're being encouraged to give the booster to women that they, you know, if their timing is right, they may well have had their first 2 doses in the first trimester of their pregnancy and be due for their booster. And we really should be offering that to our pregnant patients who are due for their booster if it's 4 months since their second dose, shouldn't we?
Definitely. So, yeah. Especially if they're in a late trimester, those antibodies are going to get across the placenta and help protect those babies and be in breast milk as well, which is great.
And look, someone else has put a really good question up, which I would like to explore a bit more. It's something that we at the PHN spend quite a lot of time having a bit of a think about, which is, Martina and Kristen, I'm happy for you coming as well, which is, are there any additional strategies to screen or educate patients about their exposure risk?
Mm-hmm.
It's sort of what you were getting at earlier, but how can we better screen or educate patients around their exposure risk to COVID?
I'm finding it as much of a challenge as Dr. Papakostas is finding it. We've had a couple of patients answer the screening questions all in the negative as they enter the practice, and then reveal at the end of their 30-minute mental health care plan consultation that isolation has just been so hard, and they're still in isolation. Like, they're still meant to be in isolation. And I had another patient admit to me that he went and got his booster while he was waiting for his PCR result, which turned out to be positive. Very grateful he didn't come to us for his booster. So I think one of the strategies is to try and have messaging on your website, especially if your patients do online booking for you, you can put some stuff up on the website. But I also think there's been such mixed messaging, you know, COVID, Omicron is mild, everyone's going to get it, and people are tired. And I think that they're just not as motivated to do the things that they've been asked to do for the last 2 years. So we're getting into that very difficult stage of the pandemic, I think.
Kristen, any other further comments on that? Or I'm happy to throw another question, which is...
Or have you got an answer for that yourself, Brendan? Any suggestions?
Well, you know, maybe if I jump in here and say, look, we have been trying to put out some messaging out to the broader community around trying to reduce the risk of exposure. It's also about trying to encourage practices to put up signs, etc., like that, and to have proper triage and screening processes in place. And really, our practice support team, who are fantastic, have been working really heavily with practices around that. But it really is trying to get that. I think there's a broader line of defence, which is around community education, that I think so. Needs to come through more strongly.
People lie. You know, we've had extra costs in the practice because we've appointed extra reception staff to actually be at the front door screening every single patient that comes in, and people just lie. They'll say, no, I don't have those symptoms, because they're here for something else. So even though they've got the symptoms, they deny them. So that it's a bit sad to see how how poor health literacy is. But you're right. I think it's a multi-pronged attack.
Now, look, can I ask?
Sorry, can I just say one other thing? And
the
other way I manage that is by wearing P2 all day and prescription eye protection goggles and having an air purifier and not taking my P2 mask off even when I'm doing telehealth. I basically take it off at the end of the day. And I get a little bit dehydrated, but it's really the only way I can protect myself. I pretty much assume that everyone's positive. It's not a nice way to have to do it, but it's a way of surviving.
At least you help protect yourself and your patients.
Yeah.
Now, look, to both of you, RAT versus PCR. We know that there have been swings and roundabouts on this, but we expect that more RAT tests will become more available, hopefully more affordable. What would you go with in a couple of weeks' time, RAT versus PCR? Go.
Do you want to go first, Kristen?
I think it just has to really depend on accessibility. You know, PCR waiting 6 hours in the sun or the rain, given what summer's been like here, just became impractical. And, you know, yes, PCR is a better test in terms of sensitivity and specificity. And with RAT tests, we have about a 1 in 200 false positivity rate, and they're not as sensitive at detecting illness. But if that's what's, you know, if you can't get out of the house, you're immobile, you've got symptoms, I think whatever's more accessible. Both are been hard to access at different times, over the last couple of weeks. But I think, you know, in such a high prevalence community pre-test probability situation where we've got a lot of spread, either test is going to perform fairly well.
My message to my patients has been, if you've got symptoms and you've got a positive RAT, you've got COVID. You know, there's a 1 in 200 chance that they don't. But in actual fact, if they've got symptoms and a positive RAT, they've got COVID. It's when you're relying on a negative RAT to let you off the hook that it's a little bit harder, because, you know, you do have that false negative issue with rapid antigen tests. So then it really depends on how important it is to know. If you're a little old lady with symptoms and a negative RAT and you don't go out and you've got family who looks after you, you know, then and they can't take you to get a PCR because they're negative and they don't want to sit in the car with you, then it's probably okay to just take it easy and keep an eye on things and contact the doctor if you're getting worse. But if you're using it to rely on the ability to work in ICU, I'm glad there are other people smarter than me making those decisions.
Yeah. Now, look, Caroline has put up a question in the chat. I wonder if you could answer that, which is around referring a patient for sotrovimab. Do you commence, and I'm going to get that word wrong again, thank you.
Budesonide. Would it be easier, Brendan, if you said Pulmicort, because that's the trade name?
It would be, thank you. So your response to that, please.
Sorry, did you want to answer?
Yep.
I'm not quite sure of the answer. Do you give budesonide if they've had sotrovimab?
If they had moderate symptoms, you could definitely still use it, because they're working very different. You know, one's decreasing inflammation in the lungs, and then the other one is essentially a synthetic antibody for those that don't have their own. And so I would start it and then see. I guess the good place for budesonide is really for those patients who are over 5 days, really, and have missed the sotrovimab window. You want to try and grab them. Having said that, though, the budesonide trial only had 1% of patients that were actually vaccinated. And so how much it adds in our sort of population when we have great vaccination rates is yet to really be seen, but don't get me wrong, I definitely do it.
it's in the Australian guidelines, but I think it's been taken off the UK guidelines. So that's interesting to know. The other thing to bear in mind is that the window of opportunity for sotrovimab is 5 days, but the window of opportunity for budesonide is 14 days. So if you've got someone who's moderate symptoms and they've called you because they're not sure if they should leave isolation and they've still got symptoms and they've got a comorbidity, that's a good time to start budesonide. It's not too late.
It'll also work great for that post-viral cough.
Yeah.
All right, that's great. Look, thank you for that. And perhaps if you could address also Gary's question. If you can see that on the Q&A, I won't read it all. It's quite a long question. Perhaps if you could summarise that.
Question. So he said, if it's the last one, when I'm dealing with infected patients suitable for budesonide already on combo, for example, Symbicort, I've added budesonide by itself, which lessens the risk of the increased LABA. Yeah, that's true. So what Gary's saying is if they're already on Symbicort, so they're already on a dose of budesonide, but if he doubles their puffer, he's also increasing their long-acting beta agonist, which might give them tachycardia, which is one of the red flags. So it might be worthwhile, if you can access plain budesonide, then having them on their usual inhaled corticosteroid LABA and then adding a little bit of extra of the inhaled corticosteroid. And Gary, that's an example of how it's really helpful for patients to have their GPs who know their comorbidities and know them, manage the system and follow the advice, but in a practical way for general practice in the community. Not having a go at the clinicians, but it's something we can contribute so that they can deal with the really sick people.
Now, I've heard around the traps that vaccination rates for adolescents, the 11-year-old plus group, is a bit lower than what we would like. Do you have any really practical suggestions for how general practice could really try to boost the vaccination rates for that group? Because my understanding is it is lower than what we would like. Any top tips to help things out to try and get that vaccination rate a bit higher?
I think that's something that's definitely worth workshopping. It's interesting because I'm not sure if the reluctance is on the part of the parent or on the part of the child. I mean, there are some children who are needle phobic, but I don't think they are the cause of the lower than we would like rates. I think that I've certainly spoken to a number of people who are parents of teenage children who were happy to have the vaccine themselves, but the anti-vax theories about, it could interfere with your fertility, it could interfere with the future children that you have, because mRNA is a very scary sounding thing. It sounds a lot like DNA. And I think for a lot of the people that I'm speaking to, the reluctance is actually coming from the parents. So they're not going to force the child. So I try to talk to the parents, but it is actually very difficult because of the misinformation that's out there. And it's very hard when people make an emotional decision, it's really hard to reverse it with rational thinking because they've made that emotional decision. It's hard to untie them from what they've already decided. So I'm acknowledging the problem and not necessarily coming up with a solution, Brendan.
Kristen, the challenge is yours, all right? I think Martina's thrown it to you. Right?
I'm going to just caveat that I work at an adult-only hospital, so I don't have much experience with the 12 to 16 population, but I could recommend some great resources to help those parents, and they need sort of to try to counteract some of that misinformation out there. So there's the Melbourne Vaccine Education Centre, as well as NCIRS's frequently asked questions for children and decision aid, I would recommend, and also the Raising Children website have all sort of been, applauded on some of the infectious diseases in forums about good resources to try and help that conversation. But I think, unfortunately, the vaccine rate in that 12 to 15 group is quite disappointing at 82% compared to adults at 95%.
Good. Now, look, I will just check to see whether we've got any further questions.
Can I just also add the COVID vaccination resources pathway? has got a section called Other Resources. And in that, there's a youth community kit, which has been released by the government. So it's also available on the federal government health website. And to be honest with you, I haven't looked at it yet, but there is some helpful advice that's designed for young people to read for themselves. So that might be also a good thing. And there's also some resources on how to speak to kids about the COVID vaccine and information for teens and parents and their guardians on that website. So maybe we should all go and have a look at those and see if they give us tools to help us address this.
If you don't mind, I was also just going to answer Hugh Tran's question on the Q&A live, because it's my pet bug. You do not get a vaccine exemption anymore if you had COVID for 6 months. So there's no vaccine exemptions whatsoever. Once someone is fully recovered and feeling better, they are safe to be vaccinated. They can choose to wait 6 weeks as per the ATARCI guidelines, but I don't do any vaccine exemptions anymore for the COVID infected patients.
Yeah, it's one of my bugbears as well. And I actually removed the AIR document that you can use to lodge an exemption from the pathways, because I didn't want to be seen to be giving that message. And I've been asked to put it back in. So I'm still making that decision because I'm with you. Our vaccination advice on the health pathways is very strong. Once you're recovered, get the vaccine. You've got 4 to 6 weeks grace if you're just due for your booster. But, you know, but unfortunately, I think everybody, you're probably getting it as well, Kristen. There are people out there who have deliberately gone and got COVID, unvaccinated, thankfully survived, and are now saying, see, I've had COVID, I now don't have to get a vaccine. And that's just frustrating.
Now, we're coming close to the end, but I do want to raise one other matter, which is that we expect that that soon, hopefully, there'll be a new vaccine, Novavax. We know that a number of people are hesitant about receiving Pfizer and we're hesitant about receiving AstraZeneca. Can you tell us what are the treatment protocols for Novavax in advance?
I haven't done that module in the vaccination course yet.
Okay, all right. Well, I'll put you on the spot, haven't I?
On a need-to-know basis, Brendan.
I need to know basis.
Just on the paediatric Pfizer ones.
Okay. All right. So what we'll do is we'll get some information from that. And I note that Kira, who leads our immunisation team, is helping tonight. So what we'll do is we'll provide a response back to you, and we'll have a look at what's happening on the ATARCI website as well.
And now, also, look, I'd like to just recommend that you keep an eye on the COVID-19 vaccination health pathways, because certainly once ATARCI has released its guidance on Novavax, that will be up on that health pathway very quickly, because they've been very responsive. So you should be able to find that information once you know that it's available to look for it.
Yeah, there are still significant numbers of people in our community who are not yet vaccinated, who have been waiting, I suspect, for Novavax. And so anything that promotes greater vaccination, would be good. Now, look, we're coming to a close now. What I'm going to do is cheat everyone and just have a look if there's any other further questions. We will send around some links as part of the session. We've mentioned a number of different resources. So we'll certainly send it around to you. And I think we're coming close to the end. We've got 2 minutes to go. So perhaps what I can do is say thank you very much to Martina. Thank you very much to Kristen. Thanks very much to the Health Pathways team at South Eastern Sydney Local Health District. They're a fantastic team. They've done a huge effort for COVID and other pathways. So my thanks to you for that. Kristen and Martina, you got a couple of tricky questions tonight, I think, but you did really well. So my thanks to you. Can I just highlight for people that we will be sending around information from tonight, and can I just give you a bit of a plug, all right? That on 22nd of February, not to be missed, this is actually really important. we are going to be running a COVID infection prevention triage and risk management in general practice. So if you want to stay open for business, treating your patients, managing your patients, then register for the event on the 22nd of February. And then, building on to some extent what Martina indicated earlier, on the 7th of March, we've got triage for general practice, which I think is pretty important in this environment. Now, we are coming up to 7:30, and so can I thank everyone for attending tonight. It's a bit rainy outside. I can hear rain on my tin roof. But thanks everyone for attending. Thank you for all the questions. There's been some great discussion. And so thank you and enjoy the rest of your evening.
Thanks very much.
Thank you, everyone.
Thanks to Kristen too.
Yes.